Now we'll go to another bout, second bout, which is bout number 23. It's related to stable coronary artery disease. And I would like to invite Dr. Surendra Gupta from Palanpur, where I work, Dr. Shabbir Gadi from Ahmedabad, Rajiv Sabnani, again from Ahmedabad, Dr. Uttam Chandarana, Dr. Nilesh Patel, and Dr. Kamlesh Fatania, our President, Association of Physicians of Ahmedabad. I would like to request Dr. Kamlesh Fatania to kindly introduce our speaker. Dr. Jasraj Panwar.
Chairpersons, please introduce all the three speakers and then the case, and then we go to the discussion.
Okay. Dr. Jasraj Panwar from Kadi, Ahmedabad. He is MBBS MD DM Cardiology, Interventional Cardiologist at Kadi and Ahmedabad. Our next speaker is Dr. Dharmadeep Humane. He is MBBS MD DM Cardiology, Mumbai. He is cardiologist and interventional cardiologist and consultant interventional cardiologist at Pratibha Hospital, and currently working and consultant cardiologist at Lifeline Hospital. And our next speaker is Dr. Rutvik Trivedi. He is consultant interventional cardiologist at Zydus Hospital, Anand. He had done MBBS, MD, and DNB cardiology from UN Mehta Institute of Cardiology and fellowship at Complex Coronary Intervention from South Korea Interventional Cardiology, UN Mehta Institute of Cardiology and Research Center. And he is also from European Society of Cardiology. So I would like to invite our first speaker to give a talk.
So good afternoon, everyone. Good afternoon, sir. Myself, Dr. Dhammadip. So should I misread the case also? I'm presenting a 70-year male with history of old inferior wall MI. With he had undergone CABG 4 years back for triple vessel disease. He has an occluded SVG to OM graft, but patent SVG to RCA graft and LIMA to LAD. So stress radionucleotide imaging was done, which showed that there is mild reversible ischemia in LCX territory. His LVEF is 45%. He has class 2 angina with class 2 dyspnea on glycerine trinitrate 6.4 milligram twice daily, apart from dual antiplatelets and high dose statin. He's already on Metoprolol 100 milligram and ACE inhibitor and diuretic. His resting heart rate is 78 beats per minute with a blood pressure of 106 by 70 millimeter. He has occasional VPC on ECG. So the preferred modality of next line of anti-anginal would be. So now I just want to stress why angina is so important in our case, because the recurrent of angina that will give rise to increased ischemia, and increased ischemia will result in higher mortality. So why we must use newer anti-anginal drugs? That is because the first line drugs like beta blockers, calcium channel blockers, nitrates, they have been not able to control angina in quite a few subset of patients who have stable coronary artery disease. So this is because of the beta oxidation of free fatty acid pathway and late invert sodium entry current. These two pathways, they can cause angina because of ischemia. So this is free fatty acid oxidation, then the trimetazidine ranolazine, which inhibit the beta oxidation, and this beta oxidation can lead to acetyl-CoA, which leads to pyruvate to lactate. Lactate can cause acidic milieu in the intracellular environment, which can further precipitate the ischemia. So this is in ischemic conditioning. As we know that the heart uses both glucose and fatty acids. So in ischemia setting, there is this increase in free fatty acid, that beta partial oxidation of free fatty acid, which will lead to accumulation of lactate, which will further lead to acidic milieu and will cause increase in ischemia. So this is how I was talking that the next is how late invert current sodium prolongation can cause ischemia. This is the channel which will keep on opening for longer time, which will lead to sodium overload, So because of the sodium calcium exchanger, which lead to calcium overload. This will result because of the increased intracellular calcium. It will cause diastolic relaxation failure, which will cause diastolic stiffening, which will further lead to ischemia. So the ranolazine inhibits the inward sodium current. So ischemia begets ischemia. So what is the outcome of diastolic stiffness? So this results in impaired coronary blood flow during diastole due to diastolic stiffness, increased ventricular diastolic wall stress, and end diastolic pressure. So what are the benefits of ranolazine? Ranolazine blocks late inward sodium current. Thus, by blocking the late inward sodium current, there is reduction in calcium overload and decreased diastolic wall stress. So along with this, it also causes partial free fatty acid oxidation inhibition, which contributes to its superior anti-anginal efficiency of ranolazine. So this is just pharmacokinetics, that it is orally available. Elimination, it was eliminated by cytochrome P450 enzyme. So this is the diltiazem, ranolazine, and verapamil have significant interactions. So those drugs which cause increase in QT prolongation, they are almost like not used in patients who are on ranolazine. So Simvastatin. So this is like Marisa trial, in which it showed that ranolazine, it increases your exercise performance at 500 and 1000 milligram BD dose at trough and as well as at the peak of exercise. This is a data from Carisa trial, in which showed that ranolazine along with beta blocker or a calcium channel blocker can increase exercise type at trough and as well as peak. Again, this data shows that it reduced weekly anginal attacks and nitroglycerin consumption. ERICA study. This is a study with chronic angina in patients who are having subset similar to our patient who had a history of coronary artery disease, stable angina, who were on anti-anginals, first-line anti-anginals, and their angina symptoms were not controlled. So we moved on to second-line anti-anginal drugs. So in this, ranolazine was found to reduce anginal events as well as increase exercise tolerance. This is that it is heart rate and blood pressure neutral, that it doesn't decrease blood pressure or it doesn't reduce heart rate. So ranolazine is effective as atenolol, that is the first line anti-anginal, in reducing the time to onset of angina, that it increases your exercise duration and the exercise capacity is increased. Thereby, your insulin resistance is also sensitivity is increased. So anti-anginal and anti-ischemic efficiency of ranolazine. So it is dose and plasma concentration dependent. So now if the anti-anginal action is not actually 500 milligram, then we can increase it to 1000 milligram BD dose, consistent throughout a broad population of chronic angina patients. There are almost like 5 major trials which have shown that benefits of ranolazine in stable angina patients, not dependent on decrease in blood pressure and heart rate. In our patient, the blood pressure is 106, so we don't want it to drop down further, and the heart rate is around 78, as great as atenolol. So the safety, like except for torsiosity pontis, which is has been shown in there is a theoretical risk, but it in clinical trials or in real world data, there are no reported cases as such. But obviously, if used with drugs which cause QT prolongation, then ranolazine cannot be used. So this is ranolazine summary, that it causes metabolic modulation. This is a newer pathway for our angina control. It causes reduction in inward sodium current, does not affect blood pressure. It is heart rate neutral, extends exercise ability, reduces angina frequency, reduces nitrate consumption, is well tolerated anti-anginal drug. So now we are moving on to that. We have two options, ranolazine and trimetazidine. Trimetazidine is another metabolic modulator. So along with that, ranolazine has one additional mechanism of action, that it causes inhibition of late sodium entry, which is another important mechanism for angina, and as well as it helps in decreasing your arrhythmia events. So in trials, it has shown that along with anti-anginal, it has anti-arrhythmic property as well. So ranolazine can be preferred. Ranolazine has been found in trials to reduce the HbA1c in patients. So how does it do it? By increasing your exercise capacity, by increasing your insulin sensitivity. So patients' physical activity is increased, thereby reducing the calories. So now about Evaporating, it is a funny current inhibitor. It causes reduction in heart rate, and Evaporating inhibits the pacemaker IF current in dose-dependent manner. So blocking this channel reduces cardiac activity, slowing the heart rate and allowing more time for blood flow to myocardium. So it is indicated in symptomatic patients of stable angina pectoris with normal sinus rhythm. So understanding Evaporating, now in beautiful trial, it has showed that it is
last 1 minute.
Yeah. So it causes decreased it doesn't improve your heart ejection fraction. So this is another real one trial in comparison of Evaporating with ranolazine, in which showed that both have similar efficacy, but ranolazine has better tolerant profile. So I will say that ranolazine kills 3 birds with 1 stone: arrhythmia, ischemia, and diastolic dysfunction. So now if one wants to add second line anti-anginal drug, then definitely ranolazine, which is a US FDA approved agent, is my choice for anti-anginal in this patient. Thank you.
Yes, wonderfully spoken. Kindly remain with us for discussion. I would like to request Dr. Jasraj if he is ready with the presentation. Dr. Jasraj, are you okay, sir? Dr. Jasraj.
Hello. Yes, sir. I'm audible.
Just bring that mouthpiece near your mouth so that we can hear it properly. Yes.
Hello. Yes. Good evening, respected teachers and colleagues. Thanks, Dr. Kamal Sharma, sir, for giving me the opportunity. In Bout 23, we have stable CAD. We have a case scenario that is a 77-year-old female with stiff old MI and angio triple vessel patient undergone CABG 4 years back. Now, patient has the angina class 2 symptoms and was evaluated and found to be occluded LCX graft. Now the patient is in a GDMT and heart rate of 78, blood pressure 106/70, and occasional revision ECG. Now we are discussing what is the next preferred anti-anginal drug to control his anginal symptoms. Next, please. Now this is a 2019 ESC guideline which states that all second-line anti-anginal drugs, including Evaporating, ranolazine, and trinitrate, they are class 2A indication, level of is B. Next, please. Evaporating is the preferred add-on due to class 2 symptoms on background of old MI with high heart rate and LV dysfunction on GDMT, according to me. Next. At the point we will discuss that do we really need to add any drug as an anti-anginal second-line drug? In this case, why not to just increase the beta blockers, as the patient is having 100 mg of the metoprolol, and we can go up to the 200 mg of the metoprolol to control the symptoms. Wouldn't that just suffice? So we have some evidence. Next. We have a study, control 2 study, which state that efficacy of the Evaporating in combination with the beta blocker versus uptitration of the beta blocker in patient with stable angina. In this, we have patients with the same age group, with the same past history of the MI, CABG patient with same risk factors, and they were all from the they were all on optimal medical guideline therapy, including beta blockers, DAPT, and statins, and they were on the most commonly used beta blockers, metoprolol and bisoprolol. So next. In this study, we can see the divergent curve that Adding Evaporating on beta blocker has a good outcome as compared to the increasing the beta blocker dose. Even side effect profile like including hypotension, fatigue, dyspnea, and bradycardia, they were more common with the beta blocker dose up titration instead of using Abradine and beta blocker. So in conclusion, next please. Next. We also have several other papers which also state that Evaporating plus beta blocker demonstrated good tolerability, safety, and a more pronounced clinical improvement as compared to the beta blocker up titration. Next, please. These two studies, associate and addition study, they also study the same phenomenon and found the adding add-on therapy Evaporating was effective and well tolerated, independent of the PCI status. Next. So point two, do we really need to address this class 2 angina, as the SD score in our patient on SPECT was 3. That is a mild, between 2 to 4, it is a mild SDS score. And as interventionist, we can think about the fixing the blocks, but in this mild SDS score, we can offer patient the medical management. So really we do need to address the class 2 angina in this patient. So we have evidence. Next please. We have clarified registry in which the 34 patients were studied from the 45 countries and followed for the 5 years, and they included the same class of patient, like more than 3 months history of either old MI, class 2 angina, dyspnea, old PCI and CBG. Next please. And in this Kaplan-Meier curve, we find that the patient having a prior MI have more CV death and MI, and even among the having MI patient, those which were symptomatic with angina have more incidence of the death and so on. So it clearly showed we need to address this class 2 angina. Next please. Point 3 is we don't think that the beta blocker and Evaporating are the same. Ultimately, they both are causing the benefit by decreasing the heart rate. So we have evidence that the Evaporating is better than beta blocker. Next please. Next, we have one study back. We have one study. We studied the Evaporating and reversible on Doppler-derived coronary flow reserve in patients with stable coronary artery disease. And here we find that both the drugs decrease the heart rate at the same level, but the coronary flow reserve was very well demonstrated with the Evaporating. Evaporating increases the hyperemic coronary flow reserve to a greater extent than the bisoprolol, despite having a similar heart rate reduction. Next, please. So the factors which may have contributed to the superiority of the combination treatment with Evaporating plus beta blocker over the up titration of the beta blocker input. The beta blocker increases the perfusion of ischemic area by prolonging diastole, but it also impairs the IVRT and thus offset the part of the benefit in terms of diastolic pressure time integral if we increases the beta blocker dose. Evaporating reduces the entry of the sodium by funny currents at the pacemaker cells and ultimately reduction of the cytosolic calcium, and thus decreases the pacemaker current and improves the reuptake of the calcium by the circular reticulum, leading to an improvement in the ventriculation also. And Evaporating also have some additional effect also, additional pleiotropic mechanism, like it's also decreases the reactive oxygen species in cardiac myocytes. It also maintains and improves the coronary flow reserves, and it's despite patient on atrial pacing, Evaporating effect can be observed, which is the we cannot see in the beta blocker dose. Next, please. Next. So Evaporating is not just a pure lowering the heart rate or IF current inhibitor. It's it do not have negative inotropic and lucitropy effect, and it do not affect the cardiac ionic channel. Evaporating does not unmask the alpha-adrenergic vasoconstriction, unlike the beta blockers, and maintains the coronary dilatations. It does not decrease the blood pressure, contractility, and AV conductions. Specifically, it does not alter the QT prolongation or repolarization and conductivity or effectivity of the ventricle and its pancreas system. Next, please. So we have a pleiotropic effect on the heart, decreases the heart rate, maintains the decreases the ROS, and by this slide we see that heart rate is the main contributor to the ischemia event. So by decreasing the heart rate, we can reduce the ischemic symptom. Heart reduction by 10 beats saves the 5 kg ATP per day. So heart reduction can improve efficacy of the heart. Next, please. Next. So benefits of heart reduction with Abradine we can see in both CAD and heart failure patient. In CAD patient, the reduction of the oxygen demand in myocyte reduces the energy requirement and reduces the ischemia and angina. In heart failure, it increases the perfusion in the coronaries, reduces load on the heart muscles, and improves the heart muscle function and prevent the worsening of the heart failure. So we have benefits both stable CD as well heart failure patient. Next. So we have a spectrum evidence from clinical trials in variety of clinical scenarios. It is also effective as a monotherapy versus over beta blocker and CCB. As an add-on therapy, we have discussed the associated addition and control 2 trial, where the addition of Abradine to beta blocker is better than titration of the beta blocker. We have also studies which about the impact on the coronary outcomes like beautiful angina subgroup and SIP and Signify study, which will be discussed next. Another point 4 is, does Evaporating affect the hospitalization outcome in patient with CAD, angina, and LV dysfunction? So we have an evidence about this hospitalization CV modality. Next, please. So this is the beautiful study which was studied in the patient of heart failure and angina and LV dysfunction, and patient was having heart rate more than 70. In beautiful trial, we have subgroup post-hoc analysis in patient which was having angina symptom. The data shows that there was the reduction in the primary endpoint, hospitalization for MI, hospitalization for MI in case of more than heart rate more than 70, and coronary resuscitation was also reduced. Next, please. So here in Kaplan-Meier curve, we can see that adding Evaporating decreases the event rate for hospitalization for fatal and non-fatal myocardial infarction. Next. We have another study from SIP trial, that is a randomized double-blind placebo-controlled trial where the 6,500 patients were studied, and to test the hypothesis that the heart rate slowing with Evaporating improves the CV outcome. This study also the same group of patients which we have in our case scenario, like class 2 angina, left ventricular ejection less than 35%, sinus rhythm, heart rate more than 78, and patient was on GDMT, and hospitalization for worsening of heart failure within the prior 12 months. Next. So the data shows that adding the Evaporating in this kind of patients decrease the primary endpoint, secondary endpoints, as well as the heart failure hospitalization and the recurrent heart failure hospitalization. Next. So in conclusion, in SIP trial, heart reduction with Evaporating in patient with heart failure and heart rate more than 70 beats per minute and on GDMT substantially decrease the risk of clinical deterioration as reflected by reduction in total hospitalization, incidence of recurrent heart failure hospitalization, increase in time to first and subsequent hospitalization. So thus the benefit reduces the total burden of heart failure for the patient and can be expected to substantially reduce the healthcare cost. Next, please. So does the Evaporating reduces the CCS or NIH class of angina? Evidence is there. Next. So we have a Signify trial where the Evaporating.
Just that last 1 minute, please.
Yes, sir. And in Signify study, it was a negative trial regarding the CV mortality and fatal MI outcome and all, but it also showed that it reduces the angina event with the significant p-value. Next. I will. To conclude, Evaporating has its own distinct set of beneficial effect, not just another heart rate lowering drugs. Combination of beta blocker and Evaporating is superior to beta blocker titration alone. More is not necessarily better. Evaporating has shown to decrease the outcome patient with a stable CAD, LV dysfunction, angina, heart failure. In patient with a limiting angina on GDMT, it will be the second line of anti-anginal drug. Thank you.
Dr. Rutvik, we can share your presentation.
Yes, sir. Am I audible and visible, sir? Hello.
Yes, you are. Go ahead, please.
Yeah. Right. Thank you, Kamal bhai, for this opportunity and congratulations for the grand success of the CADCON. The case is about a 77-year-old male who had MI, CABG, one graft is failed, is mild angina, SDS score is 3. The important points are the ejection fraction, which is 45%, is on a Metoprolol, 100 mg, not on a maximum dose. AC inhibitor has been given. Is on diuretic, probably because of his mid-range ejection fraction heart failure condition. The rate is 78. So the one speaker has already justified the role of Evaporating. The other speaker has also tried to justify the role of Renolazine. That is on the basis of VPCs which were noted. Now, important points to consider here, and I will take these points forward as my presentation flow continues, that ejection fraction is 45%. That is one thing. The anginal symptoms predominates mostly. That is what the history-wise it looks. He's a non-diabetic patient. The VPCs are present. He's on 2 anginals, beta blockers, although on a lower dose, but on a almost maximally tolerated dose of nitrates. And he's on diuretics. And I think the Renolazine, we know that it increases the QT prolongation. The risk of hypokalemia is there. So that few points one need to consider. Now, do we need a drug which has a different mechanism? And that points were highlighted by Dr. Dhamraj, that conventional drugs, they act on 2 pathways. One, by decreases oxygen demand, and the beta blockers, calcium channel blocker, and even Abradine on that sense reduces the heart rate. The second group of drugs, we know that they are vasodilators, and by increasing the coronary flow and by reducing the microvascular resistance, they try to benefit in terms of anginal relief of symptoms. Now let us take Evaporating, and I think the previous speaker has tried to justify the role of Evaporating, but the most impactful trial, if you look at the data-wise, the one is the Beautiful trial, and the important part here is the ejection fraction was less than 40. So that point is very important. All the patients which were included in the Beautiful study, which was a landmark study, they quote that the ejection fraction was less than 40. Here, the ejection fraction of the patient was more than 45. So I don't think that one should apply that rule to our patients. Second study was the SHIP study, which was also a very landmark study. The ejection fraction of that patients were less than 35%. And what I would like to highlight here is that after the Signify study, people tried to look into the matter and tried to find out why the Signify failed, why the others were quite successful in terms of hospitalization. And they found that there are different mechanisms to basically understood in the management of the coronary patient. So the SHIP study, the ejection fraction was 35% and lower, and the predominant symptoms were heart failure. Beautiful study also had ejection fraction less than 40%. Now, if you look at the Swedish heart failure data, what they found that most of the patients, those who were on 2 groups, one group, So one group of patients were having a SHIP protocol, one group was having a non-SHIP protocol. And in non-SHIP protocol patients, most of the patients were not on a maximum tolerated load, at least 50% doses of beta blocker. So that is one point which was noted. And they also noted that 14.2% of the patients were eligible for Evaporating, and over a period, those patients who are basically eligible for that becomes quite negligible. So unselective use of Evaporating was considered as a non-futile exercise, and there were more side effects which were noted. Now, Signified study, and Signified gave us a lot of insight. They tried to look the outcome in a patients who have primarily a stable angina part, where the heart rate was more than 70, angina was present, the ejection fraction was more than 40. So our patient had ejection fraction of more than 40. In fact, it is a 40. And this study showed that Evaporating added to a guideline-directed medical therapy did not improve the outcome in patient who had a stable coronary disease without clinical signs of heart failure. And there is a signal for an increase in the risk of cardiovascular event among the patients with angina who are in between class 2 to 4. And given that the primary cardiovascular effect of Evaporating is to reduce the heart rate, this result suggests that elevated heart rate is a marker of risk in CAD patient, but not a modified detrimental outcome in patient who had a stable coronary component without heart failure. So how to explain this discrepancy between a Signified, Beautiful, and SHIP? So the reduction in heart rate in patient with angina on top of beta blocker, which is almost 87% dose being used, is ineffective. And the myocardial metabolism in stable CAD and LV dysfunction were different, and they were rate sensitive. So in angina, the heart rate is reduced to adapt the energy production to oxygen delivery. In heart failure, the heart rate is reduced to adapt the energy consumption to ATP synthesis. In LV dysfunction without or with CAD, elevated heart rate is a modified risk factor. Whereas in stable CAD with preserved ejection fraction, elevated heart rate is a risk factor, but the myocardial metabolism adaptation in heart failure is quite different than a normal situation. Heart rate reduction in angina and heart failure result in a two different situations, which are actually explained by different metabolic backgrounds. So in line with the significant registry, and if we look at the data by Shripal in 2011 and 12, and a recent article which was published in 2018 in JACC, even those patients who are on beta blockers with stable coronary artery disease with normal ejection fraction, they at the end found that there were no data to support the usage of long-term high doses beta blockers because it did not reduce the mortality. So that was a point one need to understand. And on the same line with the signified, that it follows that the signified data are not so counterintuitive. What was wrong was the perception that the heart rate reduction is cardioprotective, not only in the animal experiment, but also in the human with a stable CAD, a perception that had in fact never been confirmed in a proper randomized control trial. And that could be the reason the signified showed that only chasing the heart rate was not a futile exercise. And even with the beta blocker maxima, we were bearing the small trial which was quoted, I think we don't have that long-term data, and that too I again record that Shripal Bangalore has clearly showed that in a patient with stable angina with normal ejection fraction, even a beta blocker has not reduced the mortality. Now coming to ranolazine, a wonderful drug, we all know late sodium channel inhibition was his primary reaction which was proposed, and later on came to the actions which were fatty acid oxidation inhibitor. But in a Carisa study, which was having a substantial number of patients, here the beta blocker usage was 45%. Diltiazem, amlodipine uses were almost 43, 80. So almost 80% of the patients were on other medications. And later on, it is proved that using this drug with the diltiazem and other CYP3A4 inhibitors, there was a substantial side effect, which was a QT prolongation, which was noted. However, with the beta blocker and ranolazine, the exercise duration increase was not that substantial. In fact, the side effects which were quoted were very high. We have 3 studies. And all the 3 studies, that's constipation, syncope, asthenia, dizziness, weakness, headache. See, old age, 77-year-old male can have all these symptoms which are quite cumbersome. So, in fact, in Erica study, the side effect rates were in 39%. So, the Merlin trial, which was in ACS patients, 28% of the patient discontinued the therapy. The other mechanism which was not been proven, say prevention of chronic AF, new onset AF, post-operative prevention of AF. So we don't have that data. All are basically individual supported data, which we generally follow in the current scientific era of medicines. Ranolazine as quoted QT prolongation. And this patient had a VPC. Now, do you want to inhibit that VPC? Because previously we have very low, we have trials. In fact, in the patients who have ejection fraction of less than 40 with the VPC, we have a CAS study which has failed. We have SWOT study with the sotalol, it has failed. We have studies with the abiraterone, it has failed. So our patient had ejection fraction of 40%. So why do you want to chase on VPCs only? Because VPC treatment will not modify the mortality part. In fact, you in elderly patient on diuretics will give rise to more long QTC and other complications. So that is why it is good drug, I will not like it. Now coming to a trimetazidine, and this picture, we know that it is a very popular picture. It is a Camilla, and Camilla was banned from a recent Chinese Beijing skating event because she took trimetazidine, and trimetazidine increases the exercise endurance and decreases the fatigability. This was quoted by American College JACC editor. So we know that trimetazidine increases the endurance. Now coming to cardiovascular benefit. So should we add trimetazidine with a beta blocker? We know the mechanism, in fact, that has been quoted by the first speaker, that the fatty acid during resting condition is the primary mechanism which we get our the cardiac cells get the energy, but it is not basically a very efficient pathway because almost 20 to 15% more oxygen is needed to generate the energy when we compared with the fatty acid. But what happens to ischemia? That ischemia diverts the mechanism towards a glucose oxidation pathway. But in ischemia, what happens? ischemia inhibits that pyruvate dehydrogenase, and because of that, the fatty acid pathway predominates, even though we wanted it to be on a glucose pathway. So from glucose, it goes to pyruvic acid, and from pyruvic acid, it goes to lactate, and there will be more acidosis. Even though we want a glucose pathway to become predominant, it's not going to happen in ischemia, and the pre-acid pathway will continue. And we know that pre-fatty acid pathway will basically need more oxygen for the ATP generation. So here there is a need that the drug which has a different mechanism of action without side effects and maximum tolerability should be in the line. So what this trimetazidine do is trimetazidine inhibits these three ketoacyl OS, and that inhibits your fatty acid oxidation and try to switch towards a glucose metabolism pathway. So there is 33% more ATP per oxygen millimole. There will be 6.4 per ATP with the glucose oxidation compared to fatty acid oxidation. We have studies for CAD, triple study. I'll not go into the detail, but it has clearly shown that it has reduced the episodes of angina, it has reduced the need of nitrate, and it has good quality of life. The people at 12 weeks of and it showed that it improves the function. Choice 2 studies again for the anginal patient, and it was age was up to 90 years, and it was well trained. So it has also shown that significantly reduces the anginal episodes and need for nitrates. So trimetazidine also protects. Our patient was a post-CABG patients. They were graft dysfunction, both obviously a venous graft, but we don't expect that remodeling. But it has shown that it reduces the endothelial dysfunction. Even DAPT, this Indian guidelines have also showed that it has to be second-line agent to be used in the patients who failed on a primary agents. European Society has updated guidelines class 2A. Addition, it will also help in LV remodeling. It improves the ejection fraction. Although small study, it reduces the anti-proBNP. It increases the exercise duration, and the PCR to ATP ratio, which is a marker of mortality, it increases. So lower the ratio, increase the mortality. So there was almost 33% increase, which was noted. So adding this drug to beta blocker will give rise to maximum benefit. 77% reduction in the anginal episodes were noted. So one maximum dose of beta blocker, if you look at the mechanism of action of beta blocker, which also improves the calcium handling, adding ranolazine will not be a great futile exercise. We need oxygen, we need ATP to reduce the anginal episode and improve functional capacity. So let's skip that slide. And at the end, what I like to do with my patient is 77-year, ejection fraction 45, class 2 angina, is on 2 drugs which we have used. We have an opportunity to increase the dose, but in ejection fraction more than 40%, Evaporating indication has not been justified. Same way, for the sake of VPC inhibition, where the role of ranolazine has not been justified, should not be added. And the third mechanism, which is the drug which enhances the endurance, exercise duration. We had the Olympians, those who have a healthy heart, their functional capacity improves. So obviously the heart failure patients and anginal patients' capacity will definitely improve. So our patient is 77 years, and we all want a reduction in anginal episodes and increases the functional capacity, and that will definitely achieve with the trimetazidine. Thank you.
The forum is open for discussion if there are any questions or anything.
Yes, I think all the speakers had made a good justice to their topic. The question was very reasonable. All the points by 3 speakers have been taken very well. They have done good justice to their topic.
So, I would like to give a comment. All the 3 did well, and I think if I am a treating cardiologist or a physician, I would have gone for a combination of Jasvik, Jasraj, Jasdeep, or Rutdeep, Rutraj, and same way Damraj or Damvik. So at the end, I would like to say all the 3 molecules I would have given if the pill burden and the cost would have permitted. All the 3 molecules are good enough. So all the speakers, they have justified very well. Any combination, either of them or all of them, they are good and can be prescribed. As I said, if pill burden and cost permits. Thank you.
I have one question here. There is another symptom in the patient that he has class 2 dyspnea also. So how do we attribute this symptom, whether it is an angina equivalent or it is a part of failure? So if we consider it as a part of failure, then I think beta blocker is the only drug which should be increased in this case. Any comments on this? All three drugs will take care of angina, that is fine. But what about dyspnea?
1 minute.
So if dyspnea is primarily a symptom of heart failure, you have evidence more for Abradine. If you're looking at heart failure in systolic format, also maybe there might be some evidence for diastolic heart failure. But if it's a manifestation of angina as an angina equivalent, then probably you have more evidences for ischemic remodeling for trimetazidine. So that's why it's deliberately kept in a fashion to define the therapies. Heart rate and LV dysfunction would drive it for Abradine. Arrhythmias would drive it for ranolazine, and LV dysfunction and remodeling would drive it for trimetazidine. Otherwise, I think you can choose either of the three evidences are equally strong, or you can say equally weak for all three beyond the classical anti-anginals.
Sir, can you guide us that what is the point of time when one should add Evaporating or ranolazine or trimetazidine?
Yeah, I think once you have, as I said, EF is less than 40 and heart rate is more than 70, choice is Abradine. If you have VPCs and you have a lot of VPC burden, ischemic burden and LV dysfunction or no LV dysfunction, stable CAD, then ranolazine. And if you have acute coronary syndrome, NSTMIs recently, which is now going towards stabilization, and you have ischemic remodeling, which you have to look for, then trimetazidine. Only thing that you should remember with trimetazidine is in elderly, it can mimic Parkinsonism or it can bring out Parkinsonism early. So in elderlies, my threshold for trimetazidine would be a bit high. Otherwise, in those patients, I would go for ranolazine or Abradine. In acute MIs, recently revascularized, left out a branch, secondary angina, ischemic remodeling, young patients, my choice would be trimetazidine. So, and renal failure. So these are some of the subgroups where you have more data for each of them. But ATPCI is one of the recent trials which a lot of people were working on, which actually failed for trimetazidine. That's why otherwise trimetazidine would have come ahead of the other two therapies. Abradine, of course, from SHIFT, we have data for heart failure. And that's why when you have LV dysfunction coming in, Abradine is the therapy of choice.
Thank you, Mr. Thanks a lot.
Can I ask the speakers that can we be more aggressive and try for a combination of Abradine or ranolazine, or Abradine and trimetazidine?
In fact, if you look at history-wise, if someone want to add, we have a data with SGLT2 also with the preserved ejection, mid-rate ejection fraction, so less than 40. Almost the ejection fraction is 45, we can try with the SGLT2 also. I would be quite skeptical using this Abradine in a normal ejection fraction. In fact, if you read the initial literature with the Abradine, they have in a contraindication lead with the preserved ejection fraction is a contraindication of Abradine. In fact, Abradine, a lot of people have used just for the sake of control of the heart rate in the ICU patient with the many conditions, even the recent COVID era also, and there were lot of QT prolongation and VPCs were noted. So with Abradine, the indication to me is very reasonable. It has to be a LV failure predominating the symptoms rather than a ischemic symptom, because we have data, and as I told you, that beta blockers, if you look even with the preserved ejection fraction data, the mortality benefits will not been observed. You can read a data by Shripal et al. And you can read a JACC article which has been published in 2018. So they also raised the same question that in CAD, are we have enough knowledge to treat this disease? So on that also they were very clear. So Abradine on that part, I would be quite skeptical. Kamal bhai said about Parkinson's disease, it is reported, it is very low. In fact, the restless leg syndrome was very low. In fact, the commonest side effect with the trimetazidine was the gastric upset. And I would be skeptical in using elderly patients just because their creatinines are very high or eGFR is low. The side effect rates are very high. Ranolazine, I would say I have not seen the adverse effects which were mentioned in the textbook, even though the adverse effect rates were quite high in the studies which is mentioned, but personal experience with the ranolazine is good. The only problem is a QT prolongation. And if you look at the profile of the patient, if the patients are on diuretic and SGLT2, theoretically you have chances of electrolyte imbalance. So combination with trimetazidine and ranolazine would be reasonable scientifically, but ejection fraction of 45, I would be not very keen to treat that beta blocker titration or heart rate titration very aggressively, because the asthenia and the weakness and fatigue will predominate. So that would be my answer. In fact, SGLT2 and high dose of statin, patient as already on high dose of statin, I would be happy to have SGLT2 on the board, because we have 2 studies with the ejection fraction of the mid rate and heart preserved ejection fraction, and that has shown the reduction in hospitalization for the heart failure. So that part should be considered.
Yeah, patient has a class 2 dyspnea also. So,
so Kamal Bhai has clearly answered. If you feel that is because of angina, I think you can add this. If you consider it is a heart failure, because patient was on diuretic, and diuretic we take it as a heart failure with mid-range ejection fraction. So mid-range ejection fraction with the heart failure data, if you are taking this patient on board, I think I will be happy to have trimetazidine first rather than Evaporating, because we don't have a data with Evaporating with a mid-range and preserved ejection fraction. So all the studies have ejection fraction of less than 35 and less than 40. So not for the mid-range ejection fraction, and as again record, it is not been proven in a preserved ejection fraction patient. So that is why my thinking on that part becomes very clear on that part. Ranolazine, I said fine, you can combine. My experience with ranolazine is reasonable enough, even though the side effect of QT prolongation is very high.
So this is the time we are being given actually. Now we have to go for another bout. I think Kamal Bhai, I will shift to the another bout.
Yeah, thank you everyone. Thank you, chairpersons, moderators, and all the 3 speakers. Fantastic learning for the stable CAD and all the 3 molecules. We move to the next session.
But it was a wonderful discussion all the time.
Thank you, Dr. Kamal Sharma, sir.
Thank you.